I would like to introduce our PowerPoint presentation about borderline personality disorder, presented by Juliet Gonzalez Sanes and Jorge Andres Alvarez Hernandez. This case study is about a patient named Salon Wellington. Salon Wellington is a 28-year-old American white woman who was taken to a psychiatric ward this morning after being found unconscious by her boyfriend next to an open bottle of pills. Kelvin, her boyfriend, explained that they had been in a bar the previous night where Salon got quite angry with him when he urged that he slows down on her drinking. She threw the drink at him and stormed out. 1 hour later, he returned home to find Salon breathing but unresponsive and called 911, and the ambulance took her to the emergency department. Salon woke up in the yard with a recollection of the events that occurred the previous night. However, she claimed that everything goes dark when she gets that angry. Although she feels embarrassed by her actions, what irritates her more is the fact that she is sure he will end up leaving her like everyone else. Superficial cuts were seen on her left arm. She recognized that she sometimes likes to cut herself to bring herself to reality and stop thinking about being alone. She presents with a history of psychiatric admission since she was a teenager. The patient appeared with a presenting problem of difficulty managing her emotion and behavior when she is anxious, sad, or angry. This makes the patient indulge in behaviors such as self-harming through overdosing or using an object such as a knife to cause harm or herself. The patient asserted that the problem began 10 years ago and this has led her to be abandoned by breakup with 3 of her previous boyfriends. The patient also reported that when she indulged in self-harming, which started with anxiety episodes with chest tightness, the duration is months of depressive moods episodes, self-injury, sadness, sleep disturbance. The patient often became obtunded after self-harming, which can be attributed to her overdosing and losing of blood. Salon reported that her episodes of self-harming are often aggravated by sadness, being anxious and angry. The patient is allergic to penicillin and causes her body to have rashes. The chief complaint is, I don't want to be by myself anymore. The onset was 10 years ago during college. The severity of suicidal attempts in the past, relieving factors when she's complying with her medications, aggravating factors episodes of sadness, anger, and anxiety, separation anxiety, and inability to deal with the breakup of her relationship, feeling of loneliness. Review systems. General, the patient is in mild distress, deep thoughts, and is worried about her mental status. Cardiovascular, denies chest pain, pressure, or tightness. Skin, normal color skin, warm and sweaty. Admits all scars and a recent one on the left arm. Respiratory, denies shortness of breath, dullness, and primitus. Eyes, denies vision loss, eye pain, and blurred vision. Gastrointestinal, denies vomiting, nausea, diarrhea, and abdominal pain. Ears, deny ear pain, discharge, or tinnitus. Genitourinary, denies frequency, pain or urination, and discharge. Nose, mouth, throat, denies neck pain, sore throat, and jaw pain. Musculoskeletal denies numbness, joint pain, and leg pain. Breast denies breast pain, tenderness, and discharge. Neurological denies headache or dizziness, oriented by 3, good attention and good memory span. Endocrine denies hypothyroidism or hyperthyroidism. Psychiatric admits anxiety, suicidal ideas, and depression. Denies homicidal ideas or any type of hallucinations. Vital signs, labs, diagnostic tests, and screening tools. Blood pressure 188/83, supine left arm. Heart rate 88, respiratory rate 19, temperature 97.9 Fahrenheit, weight 130 pounds, height 5 feet 7 inches, BMI 22.8, pain 0 from 10, lab test, CBC pregnancy test, TSH, syphilis, diagnostic and screening test, personality diagnostic questionnaire, and 5-item self-reported questionnaire. Definition of the disorder and differential diagnosis. Borderline personality disorder is a condition that profoundly impairs one's ability to regulate their emotions. It is generally accompanied by extremely intense feelings, and the results can be angry outbursts of self-destructive actions. The inability to regulate one's emotions can lead to increased impulsivity, change in self-perception, and harm in interpersonal interactions. In other words, BPD is characterized by a lack of stability in interpersonal relationships, a poor sense of one's own worth, and the presentation of persistent suicidal ideas. Mendez-Miller at 2022. Individuals with BPD are prone to rapid mood swings, alternating between intense closeness and intense hate of people. According to the ICD-11, a BPD diagnosis is required to have 9 of the markers articulating the DS5. The differential diagnosis of the patient can include post-traumatic stress disorder and attention deficit hyperactivity disorder attributed to self-harming, emotional instability, insecurity, and impaired social relationship. Epidemiology of the disorder. The incidence rate of BPD is slightly different in general population and lifetime prevalence rate. In the United States, BPD affects approximately 1.6% of the general population and 5.9% of lifetime prevalence. During clinical setting or primary health care visits, an average of 6.4% of adults were diagnosed with BPD. According to Mendez-Miller 2022 study, this translates to 4 times the number of cases in the overall population. The risk of suicidal is also significantly elevated in people who have been diagnosed with borderline personality disorder. In addition, depression and anxiety are other examples of the plethora of comorbidities that exist. Lastly, the gender disparity in BPD treatment in clinical settings shows that more women than men with the disorder seek professional help.
Hi, I'll be talking to you about the pathogenesis, clinical features, and some of the treatment recommendations that we found for the borderline personality disorder. When we talk about pathogenesis, we must say that the medical research that has been conducted so far does not point to a single cause or origin for borderline personality disorder. There is actually a combination of factors in terms of genetic factors, neurobiological factors, and psychosocial factors that intervene at the origin for this disorder. Um, when we talk about genetic factors, we must say that there has been found a strong presence of hereditary components, right? Typically, patients affected by borderline personality disorder have a family member already diagnosed with the disorder or even another mental health condition. Twin studies have been conducted, and a strong relationship has been found in those twins that are monozygotic twins. Typically, if one is affected, the other one has a strong chance of developing the disorder as well. In any case, will be more than a dizygotic pair of twins. As we mentioned before, neurobiological factors also intervene in the occurrence of borderline personality disorder. These intervene in the expression of the symptoms of that we typically recognize as borderline personality disorder behaviors. The research seems to indicate an abnormal development of the limbic network, which is associated with abnormal levels of serotonin. Serotonin, as we know, is a neurotransmitter that intervenes in the regulation of our emotions. So it's not surprising that these individuals present a poor management of their emotion and an impulsive behavior, which is one of the clinical marks of this condition. And now we have to talk about the most evident factors that we have involving the pathogenesis of borderline personality disorder, which are the psychosocial factors. There is a strong presence of childhood trauma related to patients that develop borderline personality disorder. Frequently, this trauma is related to physical or sexual abuse, neglect, parental divorce, or the death of one of the parental figures. Also, it could be a situation where the person was raised in an environment that experienced violence and or one of the family members suffered the condition. Also, the presence of substance abuse, it's could be part of the traumatic situation that was experienced, where the individual learns to behave in this way because he's seeing one of the parental figures behaving aggressively, emotionally, with poor emotional control. The dysfunctional parent-child relationship can teach the child that separation may cause sorrow, and therefore the separation of the parent is interpreted at some point as an abandonment. And this could explain sometimes the intense fear of abandonment that these patients experience, even with normal separation from important figures. And this could be at the cause as well for the strong feelings of anxiety and depression related to the fear of abandonment. I will be talking now about the clinical features of borderline personality disorder. There are many key behaviors that we can distinguish, right, and associate with this condition. The essential one, the main one, is the impairment in regulating emotion. These are individuals that present very strong difficulties to regulate, manage, understand the emotions that they feel. They present with high sensitivity to certain inputs from the environment, and with the poor regulation in the management that we talk about, serotonin and the poor levels that sometimes they present, they also tend to react disproportionately compared to others individuals in the community or those that don't present this type of disorder. There is a strong fear of abandonment, that, for example, we saw in the case that we presented as a case. She was very much afraid of being left by her boyfriend and reacted in a self-injurious way, or at least, or suicidal, or worst. There is a high difficulty managing interpersonal relationships. There's a feeling of emptiness, a void that has to be filled, and there's a constant feeling of loneliness that is presented by individuals with a borderline personality disorder. Another clinical feature that individuals affected by borderline personality disorder have is impulsivity, presenting violent impulses characterized by self-harm, going all the way to suicide. Impulsive behavior, whether suicidal or non-suicidal self-injurious behaviors or threats, characterize this impulsivity feature that borderline personality disorder individuals may have. In the case of our example, we saw how Salome reacted in a very violent way to her boyfriend by throwing her drink or the bottle to him. Also, as she later on presented a fear of abandonment, she reacted by taking just many pills, and obviously maybe trying to harm herself some way. Um, Another feature that we have in individuals with VPD is the disruption of their personal identity. Actually, in many cases, we found that individuals struggle to identify and construct and build an identity of themselves. This translates in they changing drastically their appearance many times, going to, for example, cutting their hair completely or dyeing the hair, changing clothes throughout the week, all the way to changing many times their name even. Um, in addition, these individuals present oftentimes with comorbid disorders, going from depression to anxiety, post-traumatic stress disorder, and also substance abuse as they try to cope with feelings of abandonment or fears of abandonment. And therefore, treatment has to be directed to handle these comorbid conditions and features, signs and symptoms that they may be presenting. Before talking about the recommendations in terms of medications, therapies, we wanted to take a moment to highlight the importance that we as clinicians need to have develop the skills, right, to handle this type of patients. Um, Oftentimes in the literature, I've found that this type of patients they struggle to find professionals that can handle and take care of them, basically because of the same features that we talked about, right? Their hyperreactivity, difficulty controlling their emotions and anger, fear of being abandoned, which limits the way for them to express themselves. And this sometimes then translates into us not arriving to the right diagnosis and therefore treating the incorrect diagnosis. We can easily confound this patients with, patients affected with bipolar disorder, uh, histrionic personality disorder, and many other comorbidities, as well as depression, for example, that then therefore could translate into the wrong treatment. In terms of medications, there is no drug that has been specifically approved for this disorder. Symptoms and signs and symptoms are treated with some medications, atypical antipsychotics and mood stabilizers, for example, because this helps the patient engage with the therapy. Which is the long-term form of treatment which provides the best rate of success long-term for them. Like I said, psychotherapies, and there are many forms of psychotherapies that can be used for borderline personality disorder and other disorders. Is the main line of treatment for this type of patient. Specifically, the literature nowadays talks about the benefits of the dialectical behavior therapy, which looks like promising based on the evidence that has been collected and the rate of success, especially when dealing with patients that have attempted to commit suicide or in reducing the self-injurious behavior that they present. There are also other therapies like schema-focused therapy, psychoanalysis. In the case, just to go a little bit more into details of the dialectical behavior therapy, they promote a non-judgmental approach, balancing with the accepting of the patient, but also leaving room for the capacity to change, right, certain aspects of their behavior and therefore improve, go for the better. They blend a cognitive behavioral strategies which focus on identifying and changing ineffective thoughts and behaviors with validation strategies which involve communicating to individuals that their thoughts, feelings, and behaviors make sense in some context and not in others. Also, the use of mindfulness, suffering tolerance, emotional regulation, and interpersonal efficacy are some of the skills that are covered as well by the dialectic behavior therapy. Other therapies, as we know, are psychoanalysis, with which identify fixations or psychosexual stages of the development and try to find the link and treat it as to how those fixations are being expressed in adulthood. To finalize, we wanted to talk about some of the cultural and spiritual considerations that we must have as clinicians when we treat patients with borderline personality disorder. First of all, we have to understand that some of the aspects, signs, symptoms, behaviors, values that we consider normal or functional in one context might be considered abnormal or dysfunctional in different contexts than ours. So it is important that as clinicians, we do our best to understand the values, the culture, the environment, and what's important for the patient that we have in front of us. Culturally, we need to understand that typically this type of patient is described in the culture, in the media. It's highly stigmatized, even in plays, in TV, movies. Characters are portrayed on a negative connotation as, you know, the character that is the crazy guy in the movie or the bad guy sometimes. And this is something that we need to have some work done, right, to promote the cultural sensitivity towards this type of patient, which is a patient that, as we described before, suffers and realizes that something is wrong and attempts to seek help to correct whatever is going on. Also, they, as patients, described a lot of difficulty to connect with the clinicians because sometimes they are difficult patients, right? They are patients that some clinicians qualify as chronically untreatable. And these are things that we have to be aware in order to avoid such, biased discrimination sometimes towards these patients. Obviously, any work that we can do in the community, at home, school levels, healthcare facilities, work environments, to promote right knowledge about the different type of personality disorders, but in particular borderline personality disorder, will contribute to increase awareness and acceptance of this type of patients. And with this, we conclude our presentation. We hope that you found value in the research that we conducted as we did, and we will leave you with the references that we use. Thank you.